Welcome to the next lecture in Session 1 of the Public Health Surveillance course. I'm Dennis Nash, a professor of epidemiology at the CUNY School of Public Health. The focus of this lecture is on the historical developments around mortality and morbidity monitoring in the U.S. So the goal of this session is to describe historical developments in the U.S. And as a former colony of England, you might guess that the U.S. adopted many of the approaches that were developed and used in England that we covered previously. So let's jump in. We'll start in the 1850s when there was a study by Lemuel Shattuck that found relationships between death and other health outcomes and people's living conditions in Massachusetts. This was considered one of the first applications of social epidemiology, and to do this kind of study, you need denominator data like Snow used for calculating death rates due to cholera by district. Not surprisingly, the report by Shattuck recommended establishing a decennial census in the United States. So the report represented an important development that increased the U.S.'s ability to be able to do more useful things with mortality and morbidity data. Prior to 1850, for mortality monitoring, states and local jurisdictions began conducting death registration. So states and cities in the U.S. did it on their own. It really wasn't coordinated nationally like in England. By 1850, however, there were attempts to compile mortality statistics nationally based on the death registration that was happening within each of the state and local areas, also leveraging the census data for rates. This slide is from New York City specifically, and it shows the all-cause death rate over time. And you can see that it goes all the way back to 1800. So New York City was doing vital statistics and vital registration, monitoring mortality and causes of death as early as 1800. And this particular graph goes all the way out to 2017. It comes from the Summary of Vital Statistics report that the City Health Department puts out every year. And I really like this graph because it contains so much history and information about mortality in New York City, but so much more than that, of course. Going back to the early 1800s, only about 120,000 people living in the old city in New York. But over time, you can see how the population of New York City increased and reached today's total of more than 8 million. On the y-axis, what you see is the deaths per thousand population. And these deaths are due to all causes. So regardless of what the person died from, it's reflected in this graph. And one thing you notice is how volatile that the all-cause death rate was in these early years of New York City. For different years, you can see the number of deaths that were caused by different infectious disease outbreaks. So in 1832, there were 3,500 deaths in New York City due to cholera. In 1849 and 1854, there were also large numbers of death due to cholera. And these were the years where there were also really large outbreaks of cholera in London, the ones that John Snow was investigating. So it highlights the connection between the two cities and how, when there are connections between cities, that there can also be connections around diseases and their spread. You also notice some of the very large peaks. In some instances, the death rate nearly doubled from one year to the next as a result of a particular outbreak. And moving along in time, however, you can see that this volatility begins to become less pronounced or dampened with time. But we do see this pretty large spike again in 1918, and this is the 1918 H1N1 flu pandemic that killed about 12,500 people in New York City. Things continued to decline over time after that, and we can see the peak in the HIV death rate in 1994 in New York City with about 7,000 deaths. In 2001, we can also see that the World Trade Center attacks killed about 2,747 people. And in 2017, influenza was a bad year and killed 1,945 New Yorkers. And here's how the cover from the 2020 Vital Statistics report for New York City looks. And it shows that the more than 21,000 deaths from COVID-19 in the year 2020, where COVID-19 was listed as the primary cause of death. It is a few decades since the death rate has really been that high in New York City as it was in 2020. It's a bit bigger than the peak for H1N1 in 1918, for example. And as of August 2023, we now know that there were more than 45,000 deaths that have been attributed to COVID-19 in New York City. And we also know that there were many other excess deaths that may also have been COVID-19, either directly or indirectly. This slide is moving to national all-cause mortality trends. And unlike the last slide, it starts in 1900 as opposed to 1800. But the all-cause mortality rate per 100,000 per year is shown on the thin black line on the graph. And it shows the same trend that we saw in the New York City graph, basically. And then there are two trend lines below that break that overall trend out into non-infectious causes in blue and infectious causes in pink. And what this highlights is that most of the decline in the overall death rate that we see in the US and that we saw in New York City is really a result of major declines in the infectious disease death rates, and not so much because of changes in the death rate from non-infectious diseases. These have been sort of comparatively level since 1900. But when you stratify by infectious and non-infectious causes, it's easier to see that after reaching a historic low in infectious disease deaths in 1980, we began to see an uptick for the first time in infectious disease deaths in quite a while, and that was sustained. And this increase represents the HIV pandemic. This slide shows the death rate only due to infectious diseases in the US going from 1900 forward, with a few details added to the timeline. And you may be surprised to know, as I was when I was learning about some of these things in public health school for the first time, that a lot of the declines in the infectious disease death rates began well before some major advances in modern medicine, like antibiotics and vaccines. And what that means is the major declines in the infectious disease death rate, which really drove overall declines in mortality for the entire country, were due to things that were more public health oriented and not due to advances in medicine. The declines were driven by things like improved sanitation and chlorinated water and improved nutrition and living conditions. These are the things that had a large population level impact on deaths over the course of the 20th century, mostly deaths due to infectious diseases. You can see also on this graph that health departments were established in the early 1900s in most states. And looking at the death rates over time on a slide like this tells you a lot about what's going on with regard to the health in the population. But there's one thing that it really doesn't tell you about, and that's the dimension of public health that reflects people who are sick with the disease in any given year but don't necessarily die from it. It's kind of like the distinction we were making between deaths, numbers of deaths, and disability adjusted life years. It's the concept of morbidity, the idea of living with a condition and the burden of public health, the burden of disease that brings. So in addition to tracking the causes of death and trends in the different causes of death over time, public health also needs to track what's going on with people who are sick but not necessarily dying, because this also greatly contributes to the burden of disease. So how do you track morbidity? It's a lot more complicated to track than mortality. Because we have death certificates and death registration, it's fairly straightforward to count deaths that occur. And maybe someone who's qualified to make an assessment can say something about what the likely cause of death might have been in someone who died and have that information recorded on the death certificate. But tracking illnesses in people who don't die is much more difficult. So how did morbidity monitoring come about and evolve in the US? Well, as early as 1741, one strategy to track illness was to ask local tavern owners to report when their regular patrons had a contagious illness or a contagious disease to local health authorities. By 1874, the Massachusetts State Board of Health began requesting that physicians voluntarily report various infectious diseases that they diagnosed for certain diseases that were deemed to be of public health significance to voluntarily report that information to the state. In 1893, Michigan became the first state to require reporting of these kinds of diseases. Requiring reporting is probably the most reliable way that you can get this kind of regular information, and that's done by codifying it in the law or the health code and enacting regulations that require the information to be reported by physicians or by healthcare providers to health authorities. These were all state level efforts, and by 1901, all U.S. states individually required some kind of reporting of specific infectious diseases from physicians to local health authorities. But the information was not really nationalized or federalized until 1914. At that time, a federal government realized that they needed to provide resources to states if they wanted that kind of information to track morbidity at the national level. So they deployed federal staff from the U.S. Public Health Service in state health departments around the country. And these staff were responsible for compiling information and data and sending it off in telegraphs to the federal level so that the federal government could begin to track what was going on nationally with regard to morbidity. And by 1925, there was full participation by all U.S. states in this weekly reporting of morbidity. So what does morbidity reporting look like? Well, here's an example of a trend line that's showing cases of polio. So not deaths due to polio, but the rate with which people are diagnosed with polio in each year. And adding on the timeline here, they've included things that could be influencing the trends, such as when vaccines became available. And tracking of COVID-19 cases and also hospitalizations are more recent examples of morbidity monitoring, as distinguished from the monitoring of COVID-19 deaths. So these are examples of morbidity reporting as distinguished from capturing information on deaths and the causes of deaths. And if you look through the words scattered through this slide, you can see I've highlighted the words here like morbidity and mortality and weekly reporting and monitoring. And eventually, these reports were all compiled into one weekly report, and this resulted in at the federal level, and this resulted in the creation of the MMWR, or the Morbidity and Mortality Weekly Report, that CDC produces every week. This happened in 1961, and they began publishing the Morbidity and Mortality Weekly Report. That's what MMWR stands for. So it tracks both morbidity and mortality related outcomes for specific reportable diseases. And you may be wondering who decides if a disease is reportable to CDC. And in fact, it's not the CDC. It's the state and local jurisdictions themselves that ultimately are authorized to require reporting in their own jurisdictions. And they do this in collaboration with each other, and they decide what's reportable to federal authorities. And that's with an organization called the Council of State and Territorial Epidemiologists, or CSTE. They work together with CDC to make annual recommendations about which diseases should be reported to CDC and published in the MMWR and other federal dissemination venues. So you'll find, in addition to routine morbidity and mortality statistics in each weekly MMWR, lots of interesting reports. So here's an example of a report of an outbreak of salmonella infections linked to ready-to-eat tofu in multiple health districts. And it's not just tracking infectious diseases here, so I include an example of cannabis-involved emergency department visits among persons aged under 25 years before and during the COVID-19 pandemic. When there are major outbreaks, both in the U.S. and also around the world, some of the first reports are often found in the MMWR. And so this is the first report of the Ebola viral disease outbreak in West Africa in 2014 on the left, and the first MMWR related to the COVID-19 pandemic was published in early February 2020. They used to publish in every MMWR in tabular format the number of deaths and select reportable diseases for each jurisdiction around the U.S., but CDC has since started disseminating this information in other venues that often allow more interaction with the data, such as CDC Wonder. So we're just going to wrap up today's session, returning to the definition of public health surveillance that we covered earlier in these series of lectures, and also talk a little bit about the purposes of public health surveillance. So with some of this historical context under our belt, let's return to this definition that we covered earlier. The definition for the course comes from the CDC, and it's also the one used in your textbook, Lisa Lee. They define public health surveillance as the ongoing systematic collection, analysis, interpretation of health-related data, essential to the planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of these data to those responsible for prevention and control. And this last part about dissemination, I tried to emphasize in some of the earlier lectures how an important part of what, for example, William Farr did with his annual report on births and deaths in England. It was a report that was disseminated. It was about not just collecting and analyzing the information and keeping it within his office, but also letting other people know what's being learned about the causes of death and their trends in England. Dissemination is an essential part of the definition of surveillance. So with that definition in mind, we can begin to think about what some of the purposes of public health surveillance are. What purpose does the activity of surveillance serve for health departments or other health entities like the CDC and the WHO, whose missions are primarily about monitoring and protecting and promoting the health of populations? Some typical purposes are listed here. To portray the ongoing pattern of health-related states and events in order to describe the understanding of the burden of diseases or exposures, such as lead poisoning, for example, to monitor trends in disease or exposure patterns, to define public health priorities. There are so many things that public health departments could be focused on any given day, too many, in fact, to allow focus on all of them. So there has to be some way to prioritize what issues are most important and what issues will benefit the most from having limited public health resources focused on them, to assess public health status, to detect outbreaks of disease and trigger public health action. This is very important. As we've seen with the COVID-19 pandemic, the longer it takes to detect an outbreak that's happening and to act on the existence of an outbreak, the more problems and issues that can happen as a result. So we want to have surveillance in place, even when there may not be things happening, so that they're ready in the event that a health threat needs to be detected right away after it begins, like outbreaks due to certain pathogens or like lead or other chemical contaminants in the water supply. Surveillance can also be used to evaluate programs, interventions, policies. We talked a little bit about that earlier. And as we talk about the public health approach, surveillance is, of course, at the very beginning, but ultimately we want to have interventions, policies, and programs that help support the control, prevention, and management of diseases and other public health threats. And we can use surveillance to evaluate the extent to which interventions and policies are actually working as intended at the population level. And finally, surveillance can be used to generate hypotheses and stimulate research, epidemiologic research and other research. So we talked a lot about morbidity and mortality and how both are important to monitor as part of public health surveillance. And you can think about each as having strengths and weaknesses, depending on your surveillance goals. But broadly speaking, mortality is something that is usually at the very end of a longer disease process. And by the time you learn about a death from a given health condition, the events that could have prevented that death likely happened years or decades prior. But still, it's a useful measure for trying to understand and prioritize what you might need to be working on first and foremost in your health department. Morbidity, meaning the occurrence of disease or illness or infection, is often more useful in identifying problems earlier in the disease process, closer to the point where public health can prevent outcomes like death. Morbidity monitoring and mortality monitoring are both important for public health surveillance, of course, and each has strengths and limitations associated with it. We'll cover examples of both of these in different surveillance systems that we touch on in the course. Morbidity monitoring tends to identify problems earlier because you're getting at the occurrences of cases and not deaths. And it allows you to work on important public health problems that people don't necessarily die from. In other words, if you only use mortality to monitor health status, some health conditions that would not be well reflected, for example, would be missed. So things like mental illness, non-fatal injuries, and food poisoning. A limitation of morbidity monitoring is that it's often harder to monitor than mortality, and there are more events to track, and there may be a spectrum of illness among people with a given condition. For example, thinking about COVID, you have people who are infected, who are asymptomatic. You have people who have mild disease that may or may not seek health care or may not get tested. And then you have people who become ill with maybe severe enough symptoms to make them go see a doctor or a healthcare provider, or even with severe enough symptoms to become hospitalized and other outcomes that lead up to death. So where then on this spectrum of disease do you begin to build a surveillance system? And how easy or hard is it to do that given the possible data sources? In the case of surveillance for COVID-19, we count all the cases that are diagnosed, but we know that there are many people with an infection that are not diagnosed because they're not tested. And this could be a problem for conducting good surveillance, or it might not be, depending on your goals. Surveillance systems that are monitoring morbidity tend to be less complete and sometimes really incomplete, which could also be a problem from a standpoint of bias. Moving over to mortality, on the one hand, strength is that it's a bit easier. There are fewer deaths for most health outcomes than there are cases of disease. So that means fewer events to track. Tracking mortality helps keep our focus on the important public health problems, that is, the leading preventable causes of death that people are dying from. It's very complete, at least in the US and other resource-rich settings. We'll talk in more detail about vital registration later on in the course, but it's highly unusual in New York City or in most places in the US for deaths not to be counted. They may be misclassified as to their cause, but the overwhelming majority of deaths, more than 99%, are counted and captured by vital registration. So that means we have the fact of death and the date of death, and some of the characteristics of the people who died, such as their age and their gender and things like that. But for most diseases, deaths are pretty far downstream in the disease process, and public health is primarily focused on disease prevention. We want to stop cases of disease from occurring to begin with. In addition, deaths often represent only the tip of the iceberg of a larger spectrum of disease, and the cause of death misclassification can occur. And so a surveillance system that relies on deaths may be counting some cases that aren't true cases and maybe missing some cases that are true cases because of misclassification as to the cause of death. And this could be problematic, again, depending on the goals of your surveillance system. Finally, when we think about surveillance in resource-limited settings, vital registration systems are often absent or very under-resourced, and they're not useful for doing disease surveillance or public health surveillance. So we'll cover some of the surveillance approaches used in resource-limited settings in another session. That wraps it up for today.